So, hi again. I just spoke on galactosialidosis, and now I'll be moving on to one of the other diseases that was uh, highly studied in Sandra's lab at St. Jude, which is sialidosis. This will be more of a mechanistic dissection rather than a therapeutic, covering the therapy for sialidosis. Sialidosis is a lysosomal storage disease, and it is autosomal recessive. Um, and it tends to be systemic in nature, as many of these lysosomal storage diseases are. There are two clinically diagnosable types, type 1 and type 2. However, again, like we just discussed so thoroughly, this disease really exists on a spectrum um, that lines up well with the type of mutation a patient has and their residual enzyme activity. Type 1 is the milder form. Onset is later in life. Patients tend to have a higher level of remaining neuron activity. However, this is still very low compared to the normal or healthy, I should say, population. The in type 2 is the more severe form, and patients have very low to no residual neuron activity, and the onset is very early in life at birth or early childhood, and the disease course is very severe and typically fatal. Neuraminidase 1 is a sialidase, so this is where sialidosis gets its name. It's responsible for processing the terminal sialic acids on any number of proteins in our body, also lipids that have these sugar tags that contribute to their function. In the status quo case scenario, you will have a nice clean removal of sialic acids and sequential degradation of these proteins in the lysosome. However, in sialidosis patients with reduced neuron activity, you have aberrant processing of these sugars. This leads to accumulation of substrates that retain their sialic acids, and this does impact their biochemical properties and functions in the body. We can see here from this publication by Mosca out of the Dotso lab in 2020 that a number of patient mutations in human sialidosis patients are missense mutations, meaning that these patients will have remnants of mRNA, but that translation into protein is very few to none, and this is what causes the disease to be so impactful. As I said in my previous presentation, Neu1 works with PPCA and beta-galactosidase in complex in the lysosome. And again, each one of these is associated with their own lysosomal storage disease that has its own unique symptoms and presentation. Over the course of Sandra's career, she has been working on sialidosis like galactosialidosis. It first appeared in the clinic in the 1960s. Its genetic deficiency was identified a decade later, and they didn't get around to actually cloning Neu1 until the 90s. Sandra's group developed one of the first animal models of sialidosis in 2000. And then from that point on, she has been very focused on dissecting mechanisms of pathogenesis and working to come up with preclinical and repurposed drugs that can ameliorate patient clinical presentation. In terms of identifying the mechanisms of pathogenesis, Sandra's lab has gone throughout the body to many different tissues, from what causes splenomegaly to what causes muscle phenotypes, as well as some indication of what could be contributing to neurological phenotypes that are seen in a subset of sialidosis patients. These mechanistic studies really do allow for us to further understand what is happening in the disease, and in that regard can inform on readouts for therapeutic efficiency, as well as possible therapeutic targets that could be outside directly targeting New1. Because really, Sandra was passionate about, or is passionate still, about just helping patients in any kind of way, um, while we are trying to get something like gene therapy present in the clinic. The first major discovery back in 2008 was the cause of splenomegaly in patients. So we found that there was a loss of retention of cells in the bone marrow, and this led to a redistribution of hematopoiesis, or the generation of the cells in our blood, to the spleen. This causes enlargement of the spleen, or splenomegaly. While this process is ongoing, there were a number of substrates of neuraminidase identified at this time, but essentially, um, the processing of VCAM1 being apparent led to this loss of retention. What's more, that came out of this was that New1 regulates a crucial process known as LAMP1 mediated lysosomal exocytosis. And this is the process of lysosomes being walked along the actin membrane, the actin filaments within cells, to the plasma membrane, in which they can release their contents extracellularly. This is a way for cells to recycle and remove excessive products from the cell. When this cannot occur, you do get accumulation within a cell and detrimental effects that come with that. At the same time, for instance, when you lack New1, you have accumulation of products because the lysosome is able to get to the plasma membrane, and but it's not necessarily able to release all of its contents. You get excessive storage, and then upon influxes of calcium in the cell, you get this massive release of lysosomal contents, which is actually quite destructive, as it can break down the extracellular matrix around cells and really break down tissue homeostasis. One of the next major discoveries was that the loss of New1 leads to the expansion of fibrotic tissue in the muscle. Um, we believe this to be a contributing factor to myoclonus and other types of muscle phenotypes that are seen in sialidosis patients. We dissected the biochemical pathways that occur. This is a major TGF beta Wnt regulated pathway, and that's really very scientific. Essentially, TGF beta is an inflammatory molecule, and what happens is these cells do not terminally differentiate. They don't end up in the final cell state they're supposed to be in. And in this regard, they expand. And this blue staining you see here in the bottom right panel here is indicative of that expansion. And this complex diagram is really a summary of the exact biochemical processes that are apparently occurring when New1 is fully deficient in mice, leading to the fibrotic phenotype that we found. When we look into the brain, what we really see is a microglia-mediated response that's occurring when New1 is deficient. Microglia are the immune cells of the brain. So when you have a cold and you get sick and your body responds to that, you have certain cells that do that. And in the brain in particular, microglia are the cells that mediate that most there. So we see that there is a shift in the morphology of these cells that tells us that they're activated. This is actually work I personally did in my time in Sandra's lab. This was the work that earned me a PhD. And so I specifically looked at one receptor that's very prominent in another sector of research in the Alzheimer's disease world. It's known as TREM2. It's a major microglia receptor that is responsible for controlling a lot of its biological function. When NUN is deficient, it accumulates in puncta, so it does accumulate within lysosomes and endosomes, and this results in altered microglial function on a whole, not just the function of that protein, where we have increased inflammatory responses. And I went on to show that TREM2 is a substrate of NUN. You get apparent processing when NUN is absent because TREM2 remains sialylated, and this results in some differences in downstream signaling pathways that leads to what we would call dysfunctional microglia. They're hyperreactive and hypersensitive to stimulus. But I think really the most important thing to convey here in this particular platform is how are we moving forward with this information we've accumulated, and how are we translating this over to patients, and what can be done for patients. So I really just wanted to comment on the most recent therapeutic publication out of Sandra's lab, which focused on AAV28 mediated therapy in sialidosis mice. I will comment that there was a repurposed drug paper that came out back in 2020 that talked about some other kind of supplement things that can be used to ameliorate some level of patient symptoms while this is in progress. I will say that unlike galactosialidosis, which responded to almost essentially every genetic therapy we threw at it, sialidosis has been a much trickier journey. The response to bone marrow transplant was not as robust in mice. Obviously, we do believe this is tied to the loss of bone marrow retention that occurred in mice. Enzyme replacement therapy was initially successful, but after 2 weeks became extremely immunogenic, which led to ultimately not a long-term solution. And I want to qualify this to say that the model that we worked in for all these years was a complete 100% NUN deficient mouse. And so when we think about these kinds of treatment options in patients, we do need to be aware that patients do not 100% lose NUN. And so we need to remember that they do have residual protein, they do have residual mRNA, and we need to think about this when it comes to our research, one, and two, treating patients. So overall, AAV-mediated gene therapy was incredibly successful in our sialidosis mice. We did a tail vein injection, and we actually injected both NUN and PPCA. So we found that injecting the combination allowed for better localization of NUN to the lysosome rather than just injecting NUN alone. And I do believe this is something that has been referenced earlier, where treatment with AAV PPCA can actually be quite successful in sialidosis patients as well. And we saw that we were able to really correct the facial morphology that was seen in our mice, as well as internal tissue morphology. We are able to reach the brain in these mice. That does become more difficult in human patients, which is why there is this shift from an AAV28 system to an AAV9 system. And again, this is being picked up by Dr. Heather Gray Edwards and Miguel and Jillian Gallagher at University of Massachusetts Medical School. They really have been great in working with us and talking to us and trying to take this therapy to the next level with very targeted gene therapy. Again, a big thank you to Sandra. She's been very passionate about, I'm sure most of you know her. She's been very passionate about these diseases for a very long time. And then everyone that has worked in her lab that has worked on these diseases. It's extremely motivating to be able to hear from patients and know that what we're doing is going to matter for these patients one day. We really hope that we can just do it quick enough to matter for the most patients. So thank you to all the collaborators, and that's my time.
Lee, thank you for sharing that beautiful work that you've done. Do we have any questions from the floor or from our online audience for Lee? Let me just ask a very simplistic question. While we're waiting for the gene therapy, you pointed out the role of neuroinflammation. Have there been any studies looking at anti-inflammatory agents to see if they have any effect in the animal models?
Yeah, so there's a paper out of Saunders Lamb from 2020 that looked at repurposing something called betaine. And I do believe that Dan is going to be able to really comment on this aspect of the work. There are some dietary supplements and things like that that can really impact the level of neuron activity in the body in a positive way for patients. Um, it is dependent on the mutation that they have, but I think that this is a very solid way to give a little bit longer of a runway to patients. You know, we know as a research scientist, personally, I do know there's a lot of steps to getting something from my bench to the clinic. And I think that using these kind of dietary supplements, repurposing drugs is a great way to try to help patients in the meantime, because we know that we need a solution and we know that we need that solution now. Um, we just also know that our hands are tied, that we can't make it happen overnight. And it is unfortunate, but we try our best. Um, and I think that some of these items can really, really help bridge that gap.
Thank you, Lee. And again, thank you for the work you've done. Oh, question from the... Could we have a microphone at the back?
So, I'm Jamie. I have sialidosis type 1. And I just had a question about my variants that not much is known about. Sandra was nice enough to email me and tell me that one variant probably doesn't have any function. The other variant we don't know anything about, but my enzyme level is 0.44, which is very low. So I also have another variant, which is MVD 70+5, which gave me porokeratosis, but it also has to do with protein prenylation and lysosome trafficking.
Can you hold the microphone up close so we can hear you?
So
Thank you.
that MVD also has to do with protein prenylation and lysosome trafficking. And I was wondering if it would have effect on my sialidosis. If it could have a compounding effect.
Sure. So I will, I'm gonna be a little speculative. I will say not necessarily based in fact, but from the sound of your second mutation in which you're impacting lysosomal trafficking, one of the features of sialidosis that heavily contributes to disease severity is excessive lysosomal exocytosis, excessive release of enzymes into the area around cells, and this breaks down the supporting material that really holds your tissues, your organs together. And so I think I'm interested. You have a very low residual percentage. It's
Right.
interesting.
I was wondering if that was why, like if this is not.
I would think that your specific new1 mutations are contributing to your
Okay.
residual
Mhm.
enzyme level. However, being a type 1 patient with such a low residual activity level, I wonder if your second mutation is not necessarily compounding as much as it might be um, slightly ameliorating. I don't want that to sound off, but if you're not trafficking lysosomes throughout your cell as efficiently because of that second mutation, then you're not going to have as many lysosomes docked at the plasma membrane that can release their content extracellularly. So you might have a slight working against each other there, not necessarily working together to make disease worse.
So it might be artificially low.
Um, I think you are low, not artificially. Let me see. So your second mutation will impact lysosomal trafficking, yes.
Mm-hmm.
Lysosomes need to be able to move throughout the cell to get to the plasma membrane, to get to the membrane between the inside of your cell and the outside of your cell.
Mm-hmm.
If they can't do that, then they can't release material that would damage that surrounding tissue. And so what I actually think is happening is that your second mutation is helping to dampen the severity of your sialidosis.
Okay.
Because with such a low residual enzyme level, that would technically fall in type 2. And I know we've discussed the spectrum of disease and everything like that, but you sound, I can't see you, but you sound pretty with it. And I know in sialidosis type 2,
Well, I had a nursing career and all of that, but my life has like just gone significantly downhill over the years. Um, with I look very normal. I can walk in a straight line. I can, you know, but somebody walk in front of me or, people
yeah.
coming at me, things are not, it's bad, my gait. So I was just wondering if about the second mutation, and where I could get information on that, who I would go to for information on that. Um,
So I can say I know I am a patient family member in a different subset of disorders over in the autoimmune world. I learned from a very young age, I was around 8 when my mother was diagnosed with multiple sclerosis, actually, that one of the best ways to learn about what was going on was to read about it.
mhm.
An excellent source of information in which you can search these specific proteins and know what's on the research front, and I do know it's very technical, um, would be PubMed. PubMed is an excellent resource to look these kinds up. PubMed. It's the United States online database of publications in which you can read about these proteins and what's known about them so far. It does sound like you've been doing some of this work already,
I've
and I know that that can be a burden to patients to have to be such a strong advocate for themselves and have to know so much about their own condition. Um, but I can tell you that in the long term, patient advocacy helps us researchers a lot.
Mhm. Okay. Okay. Thank you. Oh, and maybe Dan could send me those supplements through WhatsApp.
Yeah,
Mm.
he has his hand raised. I think he wants to say something.
Oh, okay.
Hey Jamie.
Hello.
Um, yeah, I have type 1. When I got my enzyme levels measured, it said did not detect.
Yeah.
So uh, it depends how it was measured, what tissue was measured, the variability of enzyme activity is changes throughout the body. So the fact that you came back with 0.23 of active enzyme.
Yeah, 0.44.
Oh, sorry. But you know, like we're talking sub 2%, right? Is I would say that's an outlier result, and maybe get it retested. That would be my take, because my results just don't line up with literature or yeah, my experience with sialidosis at all. Yeah. So like typically a type 1 person, you'd be looking at, you know, 11, 12% active enzyme. Yeah.
Okay. That's what I thought. Yeah. That's what I read. I did, and it seemed way above her
Just for the sake of the online audience, if you're using a microphone, please hold it close so we can hear. And just to mention, I think Dr. Kimonos, and with my hard hearing, I had difficulty, but I think she was just emphasizing the value of genetic counselors as well as geneticists to help explore the options, because even if your specific geneticist or genetic counselor isn't expert in that area, they can research the area or even connect you with researchers who might be able to answer very specific questions.
It might be better to maybe see a geneticist instead of, you know, maybe.
Sure.
Maybe do that.
And I think just again, for the sake of the online audience who may not have heard all of the discussion, Dan Peach mentioned the fact that when you're talking about measuring enzyme activity, there are a number of factors to consider. One is actually the technical aspects of the assay. Most assays for lysosomal enzymes use artificial substrates rather than natural substrates. The expression of the enzyme may not be uniform in all of the tissues. So what's measured in your peripheral blood, in your serum, or in the case of some enzymes, or white blood cells or fibroblasts, may not be the expression in your neurons or glial cells, which of course are much more relevant. So there are a number of factors that mean, whilst it is important to understand that number, I think it's also very important to understand the limitations of the number, on what it may mean as well. So that's important. Okay, well, that's great discussion. Thank you, everyone. And I think Dan, now it's time for your formal presentation of the patient voice.
Perfect. Okay. Okay. So after gene therapy, I'll touch briefly on supplements and things as I go. Yeah. So by way of an intro, I'll start with the end first. I really liked how Matthias did this yesterday. We are stronger together. It's just a fact. So I met Heather Gray Edwards and Miguel Estevez. I met Lee at an ISMRD conference. She actually saved my life crossing a road in Rome. She probably doesn't think she did, but she did. I've met countless researchers, families, and these kinds of events are just so critical to form relationships, share knowledge, especially for rare disorders, because we're spread across the globe, and without the opportunity to, like the conversation I just had with Jamie there, without this forum, this platform, that would not be possible. So first of all, thank you to ISMRD. I used to be on the board prior to COVID. I'm now on the board of Cure Mucolipidosis. I head up the research for Sialidosis. I also have known Dr. Gazzo and her team at St. Jude, including Deantha, Ida, Lee, Jace, Rosario, over decades now. So it's this collaboration of patient and researcher and is so incredible and so incredibly important to me. I now head up Cure Sialidosis, very similar to Cactus, who spoke about galactosialidosis, which is very closely related to sialidosis. We have our own community of families that face sialidosis, which Jamie has now joined. And we have WhatsApp, and it's every day. So it's an everyday thing. I talk with families around the world about their conditions, specialists, and you know, what's working for them, what isn't. Just a real quick, I'm going to time myself because I don't want to go over. So just really quickly about me, I'm one of 5 siblings. My eldest brother passed away. He spent over 2 decades undiagnosed. We've heard about rare diseases being undiagnosed. He was, even though he went to the top neurologist in New Zealand, where we're from, so I witnessed firsthand what sialidosis does without intervention. I have the same mutation. It's a combined mixed mutation, so my parents aren't related. And I am now older than my brother was when he passed away. Prior to Anton passing away, he had spent almost 15 years in a wheelchair, and he was having myoclonic seizures. And right near the end, that was happening 2 or 3 times per week. He could hardly speak. He couldn't shower. He couldn't change his shoes. Look, it gets, I love it. This quote from our community, Hussein, a dear friend of mine, his daughter has sialidosis, and he said during one of our meetings, to me, it's personal. So we can talk about the science and we can talk about the therapies, but just for a second, let's talk about the people. And again, I'll go back to what Matthias said yesterday. If we truly believe that every life is of equal value, then it shouldn't matter that one person suffering from something that's curable and one person suffering from something that isn't. Both are suffering. So I guess we've got an opportunity right now where we can take everything we've learned, and we're in a situation right now where the opportunity to actually stop that suffering exists right now. So I saw my brother, without intervention, pass away. I actually diagnosed my brother because I saw symptoms that he had early on start to occur in myself. I left the country and went to a different country and different medical system to try and get a diagnosis, which I managed to do. And then after then, I spent and have ever since then, I have been treating myself in vivo, doing my own research, and then treating myself, but under careful supervision with medical oversight and measurement. So I get blood work taken, and I also get things like TLC, oligosaccharide tests, and mass spectrum tests done every year. And like I said, for me, it's personal. My youngest sister also has sialidosis, and what I've been able to prove with the tests, she has also been able to prove, and so have other sialidosis patients. So, for example, the cherry red spot in my eye is smaller in diameter and thickness than when I was diagnosed. So, certainly it's been a bumpy road. Some weeks walking sucks. Talking sucks. Under high stress, life can be incredibly difficult. But I've got the best network of researchers around, and a community. Why does cure sialidosis exist? We exist to walk free together from sialidosis. Simple as that. That's why we're here. You can go to curesialidosis.org, or just simply curesl.org, info@curesl.org, and get information there. The papers that Lee referenced are on this site, as well as other resources. Talking about gene therapy, this is the work of AAV9 based on the work and the animal models that were set up at St. Jude. So the AAV9, here's the kicker, CTSA, which is a chaperone for new one, is the best gene therapy that has been found so far. It works both in the CNS as well as various organ tissues, and was tested on quite a severe phenotype of sialidosis, so more like a type 2. Yeah, and the future is we're actually going to test the same gene therapy in both galactosialidosis and sialidosis by itself. We have enough research and findings now to go to the FDA for a pre-IND. Once we're ready as a community for to say, yeah, we want to go ahead, the timeline for human clinical trial is between 12 to 18 months, and that's simply based on manufacturing timelines, scheduling, that kind of thing. Here's our website. Feel free to help us out. We're self-funded. We've got families going out to businesses, fundraising, doing events. Why? Because it's not just personal for me, it's personal for all of them. And what I've been able to stave off, many of our community are not in a position to do that. They've got a much more severe situation on their hands than I do. Any questions? And at the same time, more than happy to also go through the unmet needs as well.
Thank you so much, Dan. And yes, you can go through the unmet needs. Do you have the slides?
Okay. Yeah, so I actually, I'm going to do something slightly different if that's okay. It might require my glasses, but you know. Can people see that online and on the
It's small for us.
It's small? I'll make it bigger. Because the questionnaire was a little bit, I found it to be a little bit misleading. So I figured actual raw numbers led to more insight. So clearly we can see the onset of age is heavily skewed towards kind of juvenile or late onset, infantile, you know, we're talking 10, 15%. So if you want to call that type 2 versus type 1 being juvenile or late onset, yeah, it's about 10 to 15% early onset. This is where I found it kind of fell apart, which is where we classified developmental delay or neurological decline, because we assume that mobility and movement is associated with neurological decline. And I would argue that that is a misclassification. Ataxia, seizures, mobility and movement disorders all fall into like these neurological areas. In actual fact, as a patient, I've been able to go backwards and forward and improve my gait and get worse and improve and get worse. And it's not to do with my brain cognitive function. It's got to do with the enzymatic activity and substrate, which is causing myoclonus, and the myoclonus, which Lee actually perfectly demonstrated in the unreleased sialic acid, caused distortion in the signaling between the brain and the peripheral, like fingers, feet, speech, like. So really, it's not necessarily a neurological decline. However, that's how the questions were laid out. Certainly, ataxia, tremors, falling, these absolutely spot on. Hairy red spots, depending where they are, and the retina causes different kinds of sight issues. Yeah, seizures happen in about half of the patients that I know of, and they get more severe as the substrate builds up. Yeah, not everyone gets them, but yeah, it's definitely, yeah, the less enzyme activity you have, and yeah, the more buildup of substrate, certainly it is an issue. The one thing I would say here is, with sialidosis, like many of the conditions we've spoken about today, there is no official root cause treatment at all. So if you go to a specialist, the best they can do is give you a medication to suppress the symptom. So that means we're talking about an anti-seizure or a like a GABA agonist, or yeah, some sort of sedative medication, which actually does nothing to the root cause of the condition. And I'm not saying that that's unnecessary. It's clearly these symptoms need to be addressed, but masking them is not treating them. So we need to get some way to treat the root cause, which I've been doing myself in vivo for 15 years now. But hopefully, gene therapy is not too far away, and from some of the talks I've heard during this conference, there's actually some promising treatments out there for sialidosis. You can see all of these things really can be summarized down to myoclonus, which causes gait issues, shaking, movement, hands become shaky. Look, my voice is breaking up. That's myoclonus. So yeah, I think that kind of covers it.
Dan, thank you very much for that really thoughtful evaluation. And again, part of what we're trying to do here is make sure we're asking the right questions. So I think your expert commentary is really helpful. Are there any comments or questions from the audience in the room or online at this point? Again, I think you gave a very comprehensive evaluation, so that was very helpful. So let's move on to the next part, which is to talk about potential outcome measures. And you've really gone through the survey there. Just to recap the numbers, most common complaints, and as you pointed out, the term neurological decline was used, but perhaps it's better just to say neurological symptoms accounted for 2/3 of the primary concern. Sensory, which I think could be visual, they could be other symptoms as well, that wasn't specified, and developmental problems, each about 10 or 11%. The desire for improvement really reflected that. Again, the neurologic symptoms about 63%, developmental issues about 11%. Now, there's a category left blank, so I guess that perhaps it's nothing that quite fitted, but something people wanted improved. Again, the burden on patients, it was physical and pain accounted for about half of the burden. Life-limiting factors, about 10%. If we look at the burden on caregivers, very, very substantial part was emotional, 58%. Very similar in siblings, about 50%. So I think we can't underrate the importance of the emotional burden. Of course, there were physical and financial issues brought up as well. But one of the questions is what sort of outcome measures could we use? And I think the message I heard loud and clear from you was that, as you mentioned, the available symptomatic therapies are just that. They're not addressing the root cause. And in fact, when it comes to seizures, for example, in the world of neurology, we've even changed the terminology. When I first graduated back in the Cretaceous period, we used to talk about anti-epileptic drugs. We don't use that term anymore. We call them anti-seizure drugs because they're not treating epilepsy. They're trying to control the seizures. I think you made a good point. The other little point of detail, which is probably worth discussing, is what myoclonus is, and it refers to very sudden muscle contractions. I
was going to
just like to imitate jerks and
yeah,
other things,
so
but
epilepsy outside of myoclonus is typically sinusoidal, right? So sine wave, yeah? So you get this movement and it might get more violent, but it's quite evenly distributed.
That can be the case, Dan. Yeah, and I think one of the distinctions that can be challenging is that sometimes in neurology we talk about the difference between cortical and subcortical myoclonus, where it's recognized that the parts of the nervous system generating these sudden muscle contractions, as I say, I can try to imitate them, but if you put electrodes over my muscles and measure the duration of the contraction, I can't make my muscles contract as briefly as a true myoclonic jerk because that, by definition, lasts than 200 milliseconds, whereas I probably can't do it for less than 1,000 milliseconds, even though I think I'm pretty good at it. But these are discharges which may arise in the spinal cord or the brain stem, which there's no correlate with the surface EEG, whereas myoclonic seizures do have a correlate with the surface EEG. Now, we use similar drugs to treat them, particularly drugs like valproic acid, which in Australia and New Zealand is called Epilim, but in the US is called Depakote, strangely enough. It's the same drug. Clonazepam, which is called Klonopin as its proprietary name, are drugs that are useful. In Europe, there's another drug called Piracetam, which is useful for myoclonus. But again, myoclonus can be positive in the form of a muscle jerk, but it can also be negative. So there's a sudden loss of muscle tone. And that can account sometimes for people having breaks in their
absolutely.
function. And so the question is, how can we measure this? And functionally, I think one of the points that you made, particularly respect to your brother who passed away, is mobility. So a simple thing might be an outcome measure like the 6-minute walk test. Can people do that? How easily can they accomplish that? For a more fine-grained measurement, we do have a lot of measures of ataxia. In this meeting, we've talked about the SARA scale, mainly because it's been used recently as the basis for approval for a therapy for another lysosomal disorder, but there are other scales, the SCAFI, the ICARS, and so on. So it really depends on individual use. But it sounds like addressing that mobility would be something that would be really meaningful to people affected by the disease, and also something that we could use as a potential outcome measure for an intervention when speaking with the FDA. The other point you've made is to do with speech and the fact that particularly the myoclonus, and to some extent ataxia itself, can interfere with that. And so there are some simple outcome measures, things like the PATA test, but there are more sophisticated phonological tests where you can actually record people's speech and quantitate and characterize the output. You mentioned vision. And again, of course, we can measure visual acuity, which is very simple to do, but at a more sophisticated level, you can actually use optical computed tomography to measure the thickness of the retina, because we know that in patients with a cherry red spot, it's not the red that you see that's the important part, or whatever the color is, which depends on your fundus, because you're really seeing the choroid beneath the atrophy in the fovea centralis, as well as which is highlighted by the accumulation of lipid around it. That's what Warren Tay first described way back in 1880, and of course in what we now know as Tay-Sachs disease, but of course it occurs in the cherry red spot myoclonus syndrome, but can certainly be reflected in an impairment of visual acuity. But again, there's something there we can measure. You mentioned hearing, so an audiogram is a pretty straightforward way of doing that. Depending on what one found, you might need to think about things like brainstem evoked potentials. The other issues, I think, relate to the tremor itself. Is the tremor, because tremor can be very difficult to characterize, and we can do that with surface electrodes neurophysiologically, because sometimes what people perceive as tremor, which you mentioned sine waves and sinusoidal movement, because by definition, that's what a tremor is, where there's movement around an axis which is of equal amplitude in each direction. Whereas in myoclonus, there's greater amplitude in one direction. That can be hard to tell clinically, but that can be measured neurophysiologically. So that might be a potential outcome measure.
Dr. Toro at the NIH has a great app, right?
Yeah.
Which you hold a tablet in front of a patient and just get them to point to a dot, right? And it measures how close your finger goes to the dot. Now, what happens is with someone with sialidosis, you get these violent myoclonic jerks, right? And this is one thing that we could easily do for patients, is actually teach patients that sometimes fighting the tremor is the worst thing you can do
Yes.
because it's so
It enhances
violent.
it. It enhances the movement with intensity. Yeah.
Yeah, so if you're falling, learn how to fall safe. Don't try and stop the fall because you'll dislocate your shoulder. Like I've done that. So and so there are ways you can live safer with sialidosis. For example, with muscle tone, there are ways that you can maintain muscle tone while taking medication. Absolutely. Like I work out 5 days a week, knowing that if I don't, I'm not only going to be fighting a enzyme deficiency, but a weakness thing, and then it cascades. Then you've got the issue of the medication actually causing tremors. So you've got to know all of these things and balance them out, and the education around treatment and holistic treatment should be forefront. But we like the information is there, and I guess the globe is so much smaller now than when I started. When I started, I couldn't find one specialist that would even see me that knew about sialidosis. It took me 3 years to find Dr. Dowser, right? The first person to actually see me. By that stage, I'd researched for 3 years. So I don't know where I was going with that, but like we've come a long way.
I think those are really insightful comments, Dan, which we appreciate. And let's just recap. It sounds as if we're in agreement about the meaningfulness of the sort of outcome measures we discussed. I really appreciate your comments about, I think that was Camilo Toro's app you were talking about.
Yeah, it is.
Quantitating. He was a fellow when I was a fellow at NIH 35 years ago. So I think we've got some sense of things we could use. Your points are really well taken, and that is when you're talking about holistic care, you've got to address nutrition, you've got to address someone's overall fitness, think about quality of life. Remember that the symptomatic treatments you're having may themselves produce exacerbation of certain aspects of the disease. So I think they're all really important things to take into account. Very, very, very.
I'll finish on one more point, which is this: if nothing else, if you're a patient, right, and you've got whatever recumbent enzyme activity going on, first thing is if you do nothing, you're on the beach and the sand is moving. So sialidosis will progress. So every inch, every year you don't push back, it will strip away at you, right? Until there's nothing left. So do something. Secondly, do nothing out of if you're stressed, just the fact that you're firing more neurological signaling means every symptom, everyone will be worse. Your balance, your speech, your eyesight, everything will go downhill really fast. So if you're tired, sleep. If don't push yourself because your body will fail. And you know it. Like as a patient, I know how to cheat a speech test because my brain knows. I don't know how, but I know what I can say and can't before I say it. So I know, and I'm thinking all the time about 5 words that I can use instead to get the same message across, because I know when I have a word that I cannot say, I can replace it and get the same message.
Right.
So these are tricks you can learn to get that quality of life. But ultimately, we have clear ways forward, and yeah, I'll leave it there.
Right. Well, again, thank you. Your insights are really very valuable, Dan. As we've said before, people who live with the disease are truly the experts. So we thank you for sharing those insights. I think it's been a very valuable session. Lee, thank you for your sterling work across 2 sessions, all the great work you've done in the lab and for presenting.
Thanks, Lee.
And I think, one more question at this point.
Yeah, no, it wasn't a question. I think it was also just to say a few words about Dan, because obviously when I went through what I went through with my daughter and trying to find treatment, I was sharing my stories, and I think my story touched with Dan, and Dan is a massive inspiration to patient advocates like myself. I think I've seen patient advocates of kind of parents, but I haven't seen a patient advocate who has the disease and who has been so passionate, who's kind of so knowledgeable and kind of excites us to kind of push on. And I think what was great with kind of our paths crossing is that we were able to help each other. We were able to reach out to others, and we were supporting each other, not just emotionally, but making sure that we were trying to achieve that long-term goal. I think our biggest challenge at the moment is the timing difference means that at the moment Dan is actually 3 in the morning in New Zealand, so that's probably one of our biggest challenge. We catch up regularly. We've got this big project of AAV9 that we'll be able to hopefully achieve together. I'm very confident that it will be kind of next year sometime, but I just think if we didn't have patient advocates like Dan, life would be so much more difficult. And I'm just so grateful that we have someone like Dan, that we're working together, and he just deserves so much credit. And I just wanted to put a round of applause to him.